us are either working in healthcare in some way, working in nonprofit agencies, we're interacting with folks regularly, and this helps us to understand sometimes why people act the way they do, but also how we can better serve people. We're also going to talk briefly about perhaps how do ACEs affect you in your own life. I'm going to touch briefly on how we interact with other people with ACEs, and I'm going to very briefly talk about trauma-informed care and self-care as well. However, you should know that this isn't a presentation that's going to have a whole lot of information on trauma-informed care or self-care kind of topics. But if that's something you're interested in as it relates to ACEs, you're certainly welcome to email me. I have a longer version of this presentation that includes that kind of information, and I'd be happy to share it with you. All right, let's jump into the next slide. Thanks, Christina. All right, so this is an article that came out this week in the New York Times. I don't know if any of you saw it, but it was by Nicholas Kristof, who writes about a lot of social justice issues, especially around health and especially around children around the world. And when this article came out, I was very excited to see it, and I hope that the title grabbed people's attention. As a public health professional, one of the things that people ask me all the time is, gosh, you know, we have all of these public health problems. We know that adults tend to have a lot of chronic diseases. How can we prevent this? What do we even do about this humongoid problem? And my response always is, the number one thing we could do to prevent the greatest diseases of mortality in adults, right? Cancer, heart disease, diabetes, you name it, is to prevent child maltreatment, child abuse, child neglect. And that's a surprise to people because people don't necessarily make the connection between childhood stress and trauma and physical health outcomes, for example. And what I love about this article is that it goes a little bit wider in our social ecology, because it's not just, okay, a simple answer, let's get rid of child abuse and neglect. We also have to look at structural issues. And I'm sure I'm preaching to the choir with saying that, but looking at things like poverty, funding for housing, funding for schools and equity in that, food access, access to healthcare, especially reproductive and sexual healthcare. All of these sort of structural and environmental aspects of our lives impact childhood adverse experiences and childhood stress and impact our physical health in the long term. All right, next slide, please. So first, what I'm going to talk about is how does childhood stress, ACEs, adverse childhood experiences, and trauma show up? So what I'm going to do first is talk to you about a landmark study that came out in the late 90s on adverse childhood experiences. And then we're going to get a little more into detail about what those actually are and how they affect our health. Next slide. All right, so quick and dirty overview of the original ACEs study, so adverse childhood experiences study. This came out in the late 90s, and it was done out of Kaiser Permanente in California. And what they did was they they mailed a questionnaire about adverse childhood experiences to over 13,000 adults who were in the Kaiser Permanente HMO at that time, and who had had comprehensive health history evaluations there as patients. And a little over 9,000 people responded, which is pretty good for a mail survey. And they also asked people about 10 categories of abuse, neglect, and household challenges that folks might have experienced before the age of 18. And the reason that they did this study was because the investigators behind it were physicians or people who researched health and wellness or child abuse. And they were thinking, you know, could things that happen to people in childhood have an effect on them as adults? People kind of brush off some areas of child neglect or child treatment as not being a big deal. We have all these people with chronic health conditions as adults. Where does that come from? Is it just behavioral stuff we do as adults, or is there something more? And some of the physicians in this study had also noticed that some of their patients with chronic disease had disclosed things like abuse in their past. So that's kind of where this came from. And when they looked at the results of this study, they compared ACEs to health risk behaviors in adults, their health status, and their diseases. And even after they adjusted for demographic factors, they found that the more ACEs someone had, the higher their risk factors were for chronic disease, for dying earlier, than people who had not had ACEs or who had very low levels of ACEs. And this was landmark. I mean, it was the first time that it was empirically proved. And it's been replicated since then over and over and over again. And the crazy thing that happened at that time when this came out is it did not revolutionize healthcare. The healthcare industry did not really want to adopt these findings as important. And there were plenty of researchers as well who didn't want to deal with this or didn't believe the results until we started seeing them replicated. So let's go on to the next slide. So these are the ACEs categories that they asked about. So we have abuse, neglect, and household challenges. And the questions ask about emotional abuse, physical abuse, and sexual abuse. And then in the neglect category, we have emotional neglect and physical neglect. And then under household challenges, these are some kind of other things that create childhood stress or trauma at high levels for kids. So things like mother being treated violently in the home, where they're witnessing domestic violence against their mother. Household, were they in a household with a person who was misusing substances or there was substance abuse present? Household with a person with untreated mental illness, parental separation or divorce, and also if they had an incarcerated household member. Toward the end of this presentation, I'm going to show you the long version of those questions that they asked to get at all of these. But for now, I just want to give you this kind of general glimpse at what we mean when we say ACEs. And I also want to say that, you know, there's a little bit of a difference between general childhood stress and adverse childhood experiences, right? General stress is not a problem for children, right? Like, we want people to build resilience, particularly. We want children to grow up, you know, being able to make healthy decisions, being able to understand risk in their life that might not lead to good things. We want them to be able to deal with it when they have a whole lot of homework and need to learn time management, or maybe they have a conflict with a friend. That's stressful, and we want them to learn healthy conflict resolution and relationship building, right? These are stressful situations that we all experience, but that help us to grow into healthy adults. So that's kind of general stress. But we get these higher levels of stress that have an effect on our bodies and development as we're growing up. We'll talk more about that in a moment. And sometimes there are traumatic events added on to that. And so that's kind of where we're trying to get at with ACEs, kind of these more ongoing traumatic things that might be happening in a child's life. And it could also be acute traumatic things as well. So next slide, please. When this ACEs study was done, these are a lot of the health problems that they were looking at and seeing if ACEs were connected to these. And for all of the ones listed there, there was a statistically significant relationship between ACEs and all of these health problems that we listed here. And in the time between then and now, ACEs have been connected to other health problems as well. But as you can see, this is a whole wide area of risk. Sometimes when we think about childhood trauma, we can easily connect that to things like, oh, a kid who's experienced a lot of trauma probably is more likely to have suicide attempts later. But when we look at other things like chronic obstructive pulmonary disease, health-related quality of life, early initiation of smoking and having the effects of that down the line, having liver disease, we don't as easily connect these when we're thinking about childhood stress and trauma. But all of these things are part of the ripple effects of ACEs, of adverse childhood experiences. Next slide. Really quickly, I just wanted to show you some of the key findings from that original ACEs study. And keep in mind that this was with that California sample out of Kaiser Permanente. But what we see kind of in some of the highest categories there are emotional and verbal abuse, parental separation and divorce, and substance abuse by a household member. And a lot of these other things kind of were a little bit lower, but we also saw folks who had, not me, in this study, we see folks who have many ACEs happening. And we call that compound trauma, right? It's things building on top of each other that are going to make that stress effect even higher. So next slide, please. Let's take a look at that and how that works. So with this study, here's basically what they found. This breaks it down kind of easily for us. If we were given 100 American adults, kind of randomly in our country, about 33 of them would have no ACEs if we gave them the ACEs survey. About half of them, 51 out of 100, would have a lower level of ACEs, about 1 to 3. And about 16 people out of that 100 would have 4 to 8 ACEs in their childhood before age 18. And what you can see in each of these columns is that as the number of ACEs increases, so do health risk behaviors. And they can increase pretty dramatically, right? If we look at intravenous drug users, people with no ACEs, maybe 1 out of 480 of them will be IV drug users. Whereas we see that get more of a health risk dramatically when we get to 1 to 3 ACEs, right? Going between 0 and 1 can get us down to 1 in 43 people using IV drugs. And then getting to 4 to 8 ACEs, we see it get more common as well, 1 in 30. Look at suicide attempts. All of these areas are places where, as you can see, more ACEs, you're going to see dramatic shifts in the higher likelihood of health risk behaviors. So this can start to parse out for us how important ACEs are at getting folks at higher risk of risky health behaviors that are going to get them to a place of potentially having higher levels of disease and early death, unfortunately. Let's go to the next slide. One of the things that becomes really important to us when talking about childhood stress and trauma and why it has a long-term effect on us, why is it that we get from childhood stress to these high-risk behaviors like smoking, like IV drug use, is that in early life, from about, birth to about 6 years old, right, going into kindergarten, children have a massive amount of neurodevelopment, right? They're going from being born and just kind of being fussy little babies all the way to walking and talking and doing math and saying and writing their ABCs, having interpersonal relationships with other kids their age. There's a whole lot that happens there. And a lot of it is around things like sensory integration, learning what different senses mean to me as a person, smell, touch, learning not to touch a hot stove because it's going to burn me. We're starting to look at a lot more emotion regulation. We're looking at starting to have empathy for other people. We see a little bit of abstract reasoning start to happen. Mostly they're still in black and white here, but we start to learn things like creativity, expressing ourselves creatively. Um, Things like our spiritual foundations may become more important or ingrained around that age. We're looking at attachment, especially with those early ages, right? The kind of 0 to 2 years old, we're looking a lot at attachment to loving, nurturing figures in our lives. We're learning to regulate our stress response and how to moderate our response to stress physically and emotionally. So there's a lot of stuff happening here. And when we add stress into the mix, we're going to affect these areas. And these are the ages where you're going to see the hugest effect, but we know that all the way up through our child and adolescent years, we're still going to see high effects of childhood stress. Let's go to the next slide. Something that's important for us to think about too is what's happening in our brain when stress or general events are happening. So the quick overview of this is the part of our brain that deals with our emotional reactions is the amygdala. This is the place where we get that fight, flight, or freeze response when we're experiencing something acute that's extremely stressful or frightening or causing distress with us. The hippocampus is where we store memories, long-term and short-term. The thalamus is what helps our brain sort out and understand what's happening with sensory cues. Remember that there are things coming at us constantly. Every moment of our waking life, we're getting sensory input. And this is the area of our brain that sorts it out, tells us which sensory things are important in that moment and what kind of cues those things give us. And then the prefrontal cortex is all about planning, decision-making, logical behavior. And this is the area of the brain that doesn't really stop forming until we get to late adolescence, right? Early 20s. That's why we still see high risk-taking behavior in teenagers and young adults. But, oh, sorry, click next, Christina. Our natural stress response affects all of these areas. And we're seeing releases of adrenaline when we have something distressing happen. We're seeing cortisol as part of our stress response that is coming out when distressing things are happening. And during that time, our brain is affected. What happens when we experience trauma and high stress is our memory storage is mostly going to record what's happening to us with our senses. Fight, flight, and freeze. What am I smelling, seeing, feeling in this moment? Those are the things that are going to be more strongly stored than the logical parts of what's happening around us. That's why often when we talk to people who've experienced stress, they don't remember things in a logical order or in a contextual order at first. The first things people will say are the things that they felt or sensed or smelled or tasted during an event. Let's go on to the next slide. So what's the trajectory here when we're talking about ACEs? So we have adverse childhood experiences here, childhood stress, childhood trauma at the bottom. And then from there, during childhood, we start to see disruptions in neurodevelopment. And that's going to affect our social behavior, our conflict resolution, our emotional regulation. We're going to maybe see some cognitive impairment, depending on the type of abuse and neglect. As somebody continues to move through their childhood and adolescence and into adulthood, all of that starts to compound into adopting health risk behaviors. So we're going to see things like early initiation of sexual behavior, risky substance use behavior, as we're seeing this dysregulation with social and emotional cues. From there, we're going to see more disease, disability, and social problems. And for some people, that's going to cause early death. So we can see that childhood stress and trauma isn't just something that has a small effect or affects a small amount of people. It's really that this actually affects a whole giant proportion of people. And the more that people have, the likelier they are to get to this early death stage at the top. Let's go to the next slide. So what does this mean for our work? As people who are mainly service providers or working in the area of trying to improve health and wellness of our communities, there are a lot of ways that this affects our work. I'm going to focus in this moment on what it looks like in face-to-face interaction or care with people. Next slide. And part of that is recognizing less obvious signs of trauma, which may have to do with childhood adverse effects. And there are lots of things that might tell us or give us cues that somebody's experienced childhood stress and trauma that's having an impact on them when we're seeing them as an adolescent or a young adult or anywhere on the spectrum of adulthood. So somebody who's had systems involvement, they were in the child welfare system, maybe they were in the juvenile justice system or the criminal justice system. Folks who might have confusion or memory loss or just partial memories of things that happened to them early in life. People who have primarily sensory memories. We're going to see maybe more impulsivity. We're going to see maybe body language cues, more closed body language with folks. And, there are a lot of emotional or social dysregulation things we're going to see with folks as well. And sometimes that looks like a form of attachment that can be a little bit off-putting, right? People who maybe have a really hard time communicating feelings and emotions because they had to shut off that part of their response or they didn't learn that behavior. There are people who maybe overshare and overattach or dissociate and underattach or make inappropriate attachments to people in their lives. These might be some signs that there was some neurodevelopment around these areas when they were children. So these are just things that we might look out for when we're working with people that might cue us to think there may be something underlying this, and I need to be aware of that when I'm working with this person. Next slide. And people aren't always going to tell us this. When we're working with somebody in a context of health and wellness, and it's not directly about childhood abuse or neglect or stress, we don't necessarily ask about those things. And people don't feel like they obviously have to disclose those things, which is fine. We don't need people to disclose trauma to us in order to be trauma sensitive when we're working with people. But people often may not tell us about childhood trauma. That's why it's important for us to look for those cues that somebody might have been affected by childhood stress, especially when we're working with them when they're a little bit older and we're seeing a lot of health risk behaviors, or we're seeing a lot of chronic disease and things like that. These may be some of the reasons that people don't talk to us about it. And that's why it's important for us to be able to notice those cues. Let's go to the next slide. And it's also important to remember that in our work, we may not be working with individuals for a long time and be part of their longer continuum of care. It may be that we're seeing somebody once or a few times or interacting with them in a small way, but the amount of trauma sensitive response we have to them and the more that we can understand globally what might be affecting their risk behaviors, it can be a small but impactful intervention, just the small ways we work with people when we can understand that their behaviors or disease isn't just about their current behavior or their ability to stop doing that behavior. Next slide. Some of the things we might do when we're experiencing challenging behavior with someone, and that can be, someone we're working with as part of our job, it can be a coworker, a family member, a friend, is to think about how can I reframe this challenging behavior that I'm seeing with this person. What is this person, what need are they trying to meet through the behavior I'm seeing with them? And what fears or assumptions or preconceptions about getting care from me or my program or my organization might this person have? And what am I going to do to bridge that and mitigate that so that we're able to have an impact on their health and wellness? Next slide. And I also wanted to just briefly talk about what this means for ourselves when we think about childhood stress and trauma. Like we saw earlier in the pie chart of the original ACEs results at Kaiser, about 60% of people have experienced at least one ACE. And that was back in the 90s. We haven't even adjusted at this point for things like technology-based trauma or things like that. Many people have experienced at least one ACE, including some of us who are on this webinar right now. And you may be starting to think about what, if you had ACEs in your past, how that might be related to your life right now. So just wanted to let you know that the next 2 slides, I'm going to have the ACE questions on there. And if that brings stuff up for you, then you can certainly follow up on that. If you think that you don't want to read these questions, then just, maybe mute me for the next 2 slides. All right, so let's go to the next slide. Consider finding your ACEs score. That's a place to start when we're talking about this area. And if you want to see maybe how this applies to you as an individual, these are the first 4 questions there. I'm not going to ask you to tell me your ACEs score on this webinar if you're calculating it right now. We're looking at, did a parent or other adult in your household often swear at you, insult you, put you down, or humiliate you? Act in a way that made you afraid that you might be physically hurt? Did someone in your household often or very often push, grab, slap, or throw something at you, or ever hit you so hard that you had marks or were injured? Did an adult in your life before you were 18, somebody who was about 5 years older than you, ever touch or fondle you or have you touch their body in a sexual way, or attempt to have some type of intercourse with you? Did you often or very often feel that no one in your family loved you or thought you were important or special? Or maybe your family didn't look out for each other or feel close or support each other? Next slide. These are the other questions that are on the ACE questionnaire. Did you feel like you didn't have enough to eat, you had to wear dirty clothes, you didn't have someone to protect you, or maybe your caregivers were using substances to a point where they were unable to take care of you, or they didn't take you to the doctor when you needed it? We're going to look at, were your parents ever separated or divorced? And then, was your mother or mother figure, stepmother, often pushed, grabbed, slapped, or had something thrown at her? Was kicked, bitten, hit with a fist, or hit with something hard, or repeatedly hit for a few minutes, or threatened with a weapon? The next questions are going to ask about some of the characteristics about folks who were in your household. So was there somebody who maybe had a substance use disorder? Was there somebody who had a mental illness that was untreated or attempted suicide? That's certainly going to cause stress in your childhood. And did a household member go to jail or prison? Was there somebody close in your household who became incarcerated for a period of time? These are all of the things that would factor into your ACE score. Next slide. And so these are just some things you might want to think about for how ACEs might be connected to your life. You may be having your own health issues, especially chronic diseases. You might consider how childhood stress may have played a role in that, right? If you're bathed in cortisol throughout your childhood, it's going to have an effect on your health. This may also be triggering you to think about other people in your life who may have been affected by ACEs, who are having chronic diseases. You can certainly talk to your medical provider about your ACEs history, how that might be impacting your health, and what you might do to prevent more severity of disease or things happening to you. And consider too that if you've experienced a lot of ACEs, that may still be impacting your social and emotional interactions. And if you're working with folks in the public, perhaps who have a lot of ACEs, how might that contribute to any vicarious trauma for yourself that you might not necessarily recognize that connection? That's something to self-reflect on as well. Next slide. It's important for us as well to recognize the difference between self-comfort and self-care. Self-comfort are those things we do that are kind of quick, that might help us in a moment, right? The hot bath, get a glass of wine kind of thing that people recommend. Those are comforting to us in the short term, but self-care is really a lot more long-term. And again, we don't have a lot of time for me to spend on that, but I'm happy to send people more information on that. I'm also going to give you some resources. But when we're looking at self-care, part of that is looking at specifically, what are we trying to get out of that as an individual? More on that when we get to resources. Next slide. For further information in this area, or if you want to look at this in a kind of practical way that might be how you would approach working with ACEs in your own job functions, I highly recommend this TED Talk. It's 15 minutes long, and Nadine Burke-Harris is a pediatrician in Oakland, and she was working in a clinic where she was seeing high levels of ACEs among children and seeing a lot of health problems with them. And so she decided to figure out, how do you incorporate work around ACEs into pediatrics so that we can disrupt that trajectory into chronic health disease as adults. So this is fascinating. It's inspiring. You may love it. You may want to send it to somebody you know so that they are learning about this. Next slide. And the link is in the comments. Thanks, Bree. These are some references. Again, you may have a copy of these slides. Oh, wait, go back one slide. These are some references to the information that I cited here. We can make this available to you. But what I have under the resources in red is Trauma Stewardship Institute. That is a place where if you want to learn a lot more about how working with folks experiencing trauma might be affecting you, and you may be experiencing burnout, and how do you really get into an actual self-care mode that isn't just kind of the fluffy stuff, you may want to check this out. There's a fantastic book from Caroline Lipsky that's called Trauma Stewardship. I highly recommend it to anybody out in the field who is working with folks experiencing trauma and stress. I don't think you'll regret it. It's probably the best resource I've ever read working in this area. So, and you can see that through that institute. So yeah, so you have those resources, and I hope they will be helpful to you. I know that this presentation was a whole lot of information packed into a small amount of time. And again, you can always reach out to me. I'm always happy to talk through this more or provide resources if you're looking for, you know, is there a work group in my community that's working on ACEs? How might this fit into my current work with what you're specifically doing? I'm always happy to help with that. So feel free to email me. I hope this was helpful in giving you some baseline information about how childhood stress and trauma fits into our experiences as adults, especially around our health and social well-being. We have some time left, and I would be happy to take questions, or if folks want to leave comments in the chat, and we have somebody who can moderate those. So if you have questions, you can go ahead and put them in the chat now.
Great, thank you so much, Elise. I learned a lot, and I'm one of those people who knows more than the average person, and I found that very helpful. So please, let's go ahead and have some discussion. And if you can't use the chat, sometimes it turns out if people are on their phones or, it's a little harder. There is through, I think the participant section may be a way to do Q&A, but we will respond. And I see that some folks are putting some other things in the chat in terms of resources, which is really, really helpful.
That's fantastic. Another thing that I didn't mention in these slides, and I think I didn't put it in the resources area, is the CDC has a web page on their website that is all about adverse childhood experiences, and it has a lot of data, but also fact sheets and links to where you can get a lot more information about ACEs. But they also now have a chart on there that they put on recently about how to address ACEs in your community. So it's kind of practical ideas, especially around structural and systemic and environmental things that have that ripple effect out into childhood maltreatment and health and disease. I recommend that you can check that out as well.
Thanks. I wonder, Elise, because the roadmap is interested in women's health, broadly defined, lots of different groups. I wonder if you could talk a little bit about ACEs in relation to gendered social situations and how you might think about much of the data that you presented through a lens of cis trans women, other positionalities, thinking about women of color, those sorts of issues. I know there's a lot there, and that might not be an easy answer, but.
Yeah, there is a whole lot there to unpack. And so I'll just kind of give some brief information, but people can keep writing in the chat. So one of the things that we saw in this ACEs study is, you see things like risk of early initiation of sexual behavior. You see unintended pregnancy at younger ages. And so those are some of the sort of easier direct links to see when we're looking at adverse childhood experiences and childhood stress. We're going to see children who have less positive learned experiences about sexual and reproductive health and being able to negotiate safer sexual experiences. We may also have children who've, in their experiences with being neglected or abused, have learned not to bring up things that feel uncomfortable for them, or things that they don't want because they've had this experience of things happening to them that they didn't want, and they were powerless to do anything about it. Or if they tried to say no, they were maltreated further or in more severe ways. And so that has an effect out into things like sexual behavior and being able to say no, or to be able to negotiate their experiences. And, we're also going to see, and this is kind of across the board, is around conflict resolution. How do I, as I'm going into intimate relationships, how do we solve conflict in a healthy way, right? When we look at intimate partner violence or dating violence, there are actually a surprising high amount of teenagers who have experienced dating violence, physical dating violence in the past year when we survey them. And a lot of that may have to do with communication and conflict resolution and what we see as learned behavior or societally, behavior that's socially acceptable around these areas. And that can become very gendered too, in terms of perpetration and victimization. In terms of particularly talking about gender and sexual minorities, this is also a place where if these young people did not have people in their life who were nurturing, caring adults who they could talk to and know that that person is going to be there when they're experiencing something challenging or need to be emotionally vulnerable, it's going to be a lot harder for them, and they're going to experience higher levels of stress if they feel like with their household members who were supposed to be loving and nurturing, that they can't be themselves, right? We're going to see higher levels of stress with these young people. We may see more suicidality and those kinds of things happening. And then the last thing that I want to say on that too is when we look at racial inequity and ethnic inequity in these areas as well, and how that's going to affect ACEs, there is nothing intrinsic, right, about BIPOC folks, for example, if we want to use that box, that makes people more likely to perpetrate ACEs upon children. But really, a lot of what we're looking at as well is adult stress and a lot of the structural issues that have made certain communities become minoritized in terms of everything from access to healthcare to neighborhoods, safe neighborhoods, access to safe housing, food security, all of these things that are social and structural issues, many of which are based in systemic racism, that are going to create these inequities for families that can lead to higher family stress, right? If somebody's having to work 2 jobs 6 or 7 days a week as an adult, they're going to have a lot more stress. That can have a ripple effect out into what's happening in their household to children. It's going to have an effect on children's safety when there's less positive surveillance for them. So those are some of the ways that we're going to see these high levels of ACEs happening in ways that are fixable with our systems, but that are really kind of contextually, unfortunately, making it easier for ACEs to happen to children. And the ACEs questions focus on household dysfunction, but I think that we can also be looking at neighborhood or other close folks. This focused a lot on parents, within a home, but we know that, right, there are children who don't necessarily live with parents, or their primary caregiver, if their parent is working a lot, the primary caregiver may be an older sibling or somebody else from their family. It might be a neighbor. It might be they don't have an after-school program. So there are a lot of things that we should also be looking at there. And I think, unfortunately, that would give us an expanded idea of how many ACEs are happening. And then if we look into foster care system, right? Children who've been removed due to child maltreatment may already have these challenging attachment responses or stress responses. And that's going to make it, that's just one of the few things that makes it harder when they're being moved into somebody else's home that they don't know, or they get passed around because they're seen as problem children. And that's not the issue here. Or maybe they're put into a group home where there are dynamics happening that compound their stress, or there are not necessarily staff who can give them the one-on-one attention they need to be able to make relationships with trusting and caring adults. So we have all of these things that happen too, where we could be addressing ACEs in our various systems that children find themselves in.
Yeah, thank you, Elise. I see that Bree has a question.
And I know this isn't an easy answer or even answerable, but I just also want us to kind of consider COVID and the pandemic. I mean, and what that has or hasn't done to our children, for a variety of things. And when I was listening to what you were talking about, there's just so many avenues that just adds a confounding factor on top of it all.
Yeah, absolutely. And we should be thinking about that right now. And I wish that it was a larger part of the conversation on whether and how or why we should be opening schools, which I'm not going to take a personal position on in this moment, but what it has come up that teachers tend to be the first people to recognize child maltreatment happening with a kid or have a suspicion of it. and kind of lead into that intervention area where something can be addressed or resolved, or they are potentially removed from that maltreatment. And if children aren't going to school where they're going to have this oversight by teachers who are mandated reporters, then we may be having larger, more severe effect of childhood maltreatment on these kids. And we know that there are thousands, I mean, tens of thousands at the very least, of kids who are deemed missing because the school system has not been able to contact them or their families. They're not attending remote learning for many reasons, but schools have not been able to find them. And it may be that many of these children are experiencing childhood maltreatment or abuse, and we don't have any way of easily finding that out. And there's certainly not the capacity, unfortunately, in education or social services to be able to address that need.
Yeah.
You know, it's a pretty big issue right now.
Mm-hmm. I anticipate that in the next year plus, we're going to see much more research about COVID and all the ways that it has impacted families, communities, women's lives, sexual violence, kids, et cetera, fill in the blanks. And, I welcome that research. I think we need to know, what's happened. I see that we don't have any more questions. Does anybody have a burning thing they need to say? If not, I think I'm going to wrap us up with thanks to Dr. Lopez for this very, very illuminating talk. And I want to thank all of you for attending and remind you that our next event is next week. As I mentioned in the video, we're doing one a week in February. This will be on February 11th at 5 p.m. And we invite you to bring your favorite after hours beverage to hear Dr. Carolyn Fuller from 1 in 10, who will be discussing bringing LGBTQ+ cultural competency into your clinic or office. And we hope that you'll be able to join us for that. And have a lovely day and a lovely weekend. And we appreciate your time and your attention today. Thanks so much.
Thank you.